So to continue with what we did last time, what we started to talk about is the cardiac adaptation to training, or what the athlete's heart, for example, would look like. So some of the things that I've been explaining before was that when you do exercise, what in the end, what you need to do is you need to increase your cardiac output. And there's a couple of ways to do that. The most obviously would be to try to increase your stroke volume, which means that with every beat, you would increase the amount of blood that is being ejected. Or the other way of doing it is, of course, increasing your heart rate. So with the same stroke volume, obviously, if you eject more times per minute, then your total cardiac output will be increasing, of course. Now, when you look at stroke volume, we can increase that in two ways. One is, of course, deform more, right? So that you really do more strain, and then, of course, you will eject more of what's in the ventricle. Or you can try to dilate the heart, because as we explained when we talked about volume loading, for example, when you increase the size of the heart with the same amount of deformation, you obviously have a much higher stroke volume, given that it's always like the outer rim, so the displacement of the endocardium that you eject. And so the volume increases when the size of the heart increases. Now, when you start to look at different individuals, you see that different individuals use these different mechanisms. Since in the end, we have, in a way, three parameters in brackets that can be adapted. That means that every individual will do it differently or can do it differently. And that's also what you see in reality. And even in some individuals, especially when we're talking about the deformation, what you see is that the deformation can actually decrease. And that's also something we said in the past, especially when you go to very, very high heart rates, your total amount of deformation will decrease because of the fact that your filling from the previous beat was not full because you didn't have enough time to fill. So this is obviously happening with quite some athletes. And you can already imagine that if the deformation goes down, then obviously in order to increase the cardiac output, you would have to increase one of these two parameters. And what you very often see is that the ones that decrease their deformation will have to increase their heart rate proportionally much more in order to be able to generate the same cardiac output, because cardiac output is what is demanded by the muscles, and that will depend, of course, a little bit on the size of the person, but in general, that will be more or less the same that is being asked if you do the same amount of exercise in some way. And then we ended last time with looking at some hearts, and these are two hearts these are hearts of two individuals before and after kind of a quite challenging race. And what you see here is that before the race and after, if you compare this person, and especially focusing on the right ventricle, what you see, the right ventricle here is hypercontractile and it's clearly not dilated. So it means that this seems to be a right ventricle that indeed can increase the cardiac output, probably even has increased the strain a little bit. If you would look here at the ring displacement, which is like a rough kind of estimate of the strain, you see that it might be even increased. So this is clearly a good adaptation to exercise. Now, if we look at this ventricle here, well, first of all, when you compare these two, you see already that this ventricle looks different. So what you see is that this ventricle seems to be shorter and kind of wider. So you see that this is a more spherical ventricle, and overall it might be that, or it looks like this ventricle could be dilated, especially also when you look at the scale of these images. So you really see that this might be already at baseline, so without any exercise there might be already some change. And here you see after exercise, and you clearly see that now, especially compared to this, you see that this ring motion has clearly decreased, and you start to see also that the wall starts to move inwards, like a little bit like a piston in some ways. And so you see that this is clearly a much worse adaptation than this. While this one, you don't see any degradation. Here you see some kind of signs of degradation at baseline, but clearly after exercise, you see that this ventricle is totally not happy. So this already shows you that different individuals can act differently on this. And it seems that from this, that there might be some potential problems with the right ventricle in some of these individuals. And we're going to go a little bit more detail there. Yes, of course.
There is a movement in the apex in the right ventricle, or?
You mean that the apex overall is moving?
Yep, it seems
Yeah.
so, or at least.
Yeah, if you look at this one, indeed, there seems to be a differential, and there seems to be also when you, now it's not focused on this, there seems to be some timing difference. And what you also see is this one, it seems that the right ventricular apex is going towards the real apex, while here, the apex is clearly left ventricular. And this is something typical. Maybe when we talk about the right ventricle a little bit more, I mean, I have some images later on also from pulmonary hypertension. And that's what you see is that if you start to overload, especially pressure overload the right ventricle, what happens is that the apex starts to become, or the right ventricular apex starts to become apex forming for the whole heart. And also, if there is a timing difference between left and right, which will happen if you pressure load it, then you start to see that the apex might be starting to move or to wiggle. Actually, when you look at general hypertension and you look at the left ventricle, what you also see is that in hypertension, the apex starts to move a little bit. So as soon as you have some differential loading in both ventricles, you can start to see this. And so that's what you effectively see here, which of course makes that TAPSE is sometimes difficult to measure, because here, of course, if you take only the ring displacement and you assume that that's the full kind of longitudinal deformation of the ventricle, then that's not correct, because that assumes that the apex is stationary, which clearly it isn't. So that means that even visually looking at this displacement will be an overestimation of the overall strain, given that the whole ventricle moves a little bit in that direction.
And that also happens in the physiological ventricle, or?
Normally not. Normally not. Normally in the physiological ventricle, well, you see here, this is more or less a physiological ventricle. Right? You see here, this apex is virtually stationary. And you see that the septum is actually, especially the apical septum, so you see the septum is one continuous straight line and is almost not moving. While here, you clearly see that the apical septum is moving transversely in some ways. So that is clearly the influence of the loading, or differential loading, let's say it that way.
Thanks.
Now, one thing is that you see that the right ventricle seems to be involved. Now, the other thing is also that when you start to look at the right ventricle of these individuals, that you start to see differences there also in the appearance of the right ventricle, not only in deformation, but even in morphology. And especially here, when you start to look at these different ones, if you really look at this apex of this right ventricle, what you see here is like, okay, this looks like an apex which is kind of open, let's say it that way. But what you see here is you see that there is a lot of trabeculation, and here is also quite some trabeculation. So here you see the moderator band, and here the moderator band is here also. But what you see here, especially in this one, what you see is that the trabeculation is so thick that there doesn't seem to be any volume of blood inside anymore. So what you start to see is that you get hypertrophy of the trabeculations in the right ventricle, and that means that the trabeculations are growing in such a way that it almost obliterates the cavity inside. And you can already imagine that if this is normal tissue, what likely is the case, this is probably not damaged tissue, but even if it's normal tissue that can contract, at the moment that it starts to contract, I mean, there's nothing to eject there. So there's almost nothing that it can contribute to the ejection. So you see that a lot of the perfectly normal tissue in some ways cannot be recruited in order to increase the cardiac output. And this seems to be also very individual dependent. So here again, when you look at deformation, one of the things that I said is like, you can only deform if you fill. So that means that with very high heart rates, you will see that the deformation goes down because there's no time to fill the ventricle, and the ventricle stays smaller. And of course, you can only eject what you filled in the previous part. Similarly, it's here, it's like there is nothing to fill because everything is obliterated. There is no volume inside. And of course, it cannot contribute then to ejection, but also it cannot deform in some ways. I mean, there can be, if you measure the deformation here, deformation will be very low because there is nothing to deform in some ways. So you have to be very careful also when you interpret the deformation here, because it might be that it's not related to tissue damage, which would decrease the strain, but it can be because there's just no volume there. And this is something that I think is quite important, and you can already start to speculate now. It's like, why do you see this? Huh? So, and we know from when we started to talk about pressure loading, hypertrophy is something which is mostly coming as the consequence of a long-standing kind of increase in wall stress during contraction. And so it's likely that there's some pressure loading. So if you have a ventricle which is pressure loaded, it becomes hypertrophic. In the left side, that's very beneficial, because what we saw there is that your wall becomes thicker and actually the cavity can become a little bit smaller, which is kind of a very good adaptation to pressure loading. And in the left ventricle, there's no problem in the sense that the apex is okay, it is trabeculated, but it's not that you have this structure like a moderator band going transversely. So a hypertrophic left ventricle is actually homogeneously hypertrophying without kind of hampering potentially some of its volume internally. The right ventricle, because of its morphology, is very different. The right ventricle is never made morphologically in order to have pressure loading. A right ventricle is a volume pump normally working under low pressures. And you see that if you start pressure loading, it might be that there is this maladaptive kind of hypertrophy in some ways that while in itself hypertrophy is good, it obliterates the cavity volume. And you can actually see that also when you start, for example, to look at systemic right ventricles. So maybe another session we can talk a little bit more about this, but what you see is that in some, especially congenital heart diseases, what you see is that the morphological right ventricle is actually connected to the systemic circulation. That can be in this way, this is a congenitally corrected transposition. So where you see that the right ventricle is connected to the aorta and is connected also to the left atrium. So that means that that is a normal circulation. While on the other hand, you can also have a kind of full transposition. So where you had a baby that was born with the aorta coming from the right ventricle, but the right atrium connected to the right ventricle, which of course is not a viable situation after birth. When the ductus arteriosus closes, this is not viable anymore. And so what they do is they do some surgery. And in the past, they did surgery where they would keep the right ventricle as a systemic right ventricle. And what you see here, so this is like an adult patient that has a systemic right ventricle. And you nicely see here how the apex is fully kind of covered with tissue, so with hypertrophied trabeculations. And you see that now the base is kind of very, very dilated. You see also a little bit the trabeculations here. So even in the free wall, there's more trabeculations in the right ventricle. And so you see, while you have, if you look at the potential volume in some ways of this right ventricle, this is like huge, but the effective volume that is filled with blood that can easily be ejected is much, much smaller. So this is something that you have to look at, and that can be a potential consequence, which can be, of course, kind of deleterious for the person that has it, because especially these systemic right ventricles, they fail after a while. And you can also imagine that for the athletes, that the ones that have this is potentially also a problem. Now, the other thing that it actually says that you see as an athlete is, as I said before, is like hypertrophy is very typical, the consequence of pressure loading. So that means that for these athletes have long-standing or have very regular high pressures in the right ventricle. And this is something which is important, and we'll come back to that later on, the fact that exercise can indeed induce this. Now, another morphological characteristic that you see is if you start to do MRIs in athletes, what you see is that quite some, it's like 1/3 of the athletes that in principle have no problems with coronaries or anything, they do have late enhancement, so gadolinium late enhancement in especially the hinge points of the right and the left ventricle. Now, keep in mind, gadolinium and late enhancement is something tricky in some ways, because although mostly people relate this to fibrosis, what it actually says is that you have a different contrast dynamics there, where the contrast agent actually gets stuck in some ways in these areas. which means that it can be fibrosis, but there can be other things also. It can be that it's related to some edema or something like that, or kind of structural changes, fiber disarray, or anything. But here again, what it shows is that it seems like there's something going on here, and which is likely related to increased wall stresses there. So which again would be pointing towards that you have high pressures in the right ventricle, and because of its morphology here, what you can see is that there locally you might have at some point very high pressures, very high wall stresses. So there's a lot going on, and one of the things is also that we don't know so much yet, and studies are being done. It's like, how is this related to the amount of exercise that you do? What is like professional versus non-professional? What is endurance sports versus more like power-related exercise? Is there a gender difference? What is happening structurally? What is happening functionally? One of the things that I said before is very often you see low strains in athletes, also in the left ventricle. But of course, if you only look at baseline, what you then have is, of course, since they have very often these enormous hearts, then in order to generate the baseline stroke volumes, they don't need to deform so much. So baseline deformation can be down, not because of a problem with the myocardium, but just because the ventricle is so high, the stroke volume is so high that they don't need. But of course, when you then start to look at exercise, then it might be that a lower strain becomes a problem. Or if you start to see differential changes in deformation, whether it's changes in the basal or whether it's changes in the apical deformation, you can also see that there might be some problems. So there's a lot of things that we need to investigate. And then Gabrielle did a very nice study in just looking at the geometry of athletes and trying to see whether you could find, with kind of statistical shape analysis, whether you could find a specific shape change of athletes, which then potentially is also related to the amount of exercise that they can do, or their like oxygen kind of consumptions or potential to increase this during exercise. And what you see is, in general, when you look at the ideal or the kind of most athletic athletes in some ways, or the extreme kind of remodeling of the athletes, first of all, there are some changes in the left ventricle, which we expect, and which predominantly would be dilatation. There might be some regional differences there, but you see like that is kind of some changes, but not enormously. But what is much more important is that when you start to look at the right ventricle, you see that there's much more changes in the right ventricle compared to the left. So again, pointing to the fact that the right ventricle seems to be differently involved in exercise as compared to the left ventricle. Keeping in mind that both of them always have to generate the same volume. So unless you have a shunt, the cardiac output of the left and the right is exactly the same, since of course it's a circulation in series. And the other thing that you also see is that it's predominantly in the right ventricular outflow tract, which seems to be widening, which can make sense in some ways, of course, because you have to increase the volume load. So of course, if it's wider, it might be easier to do it at lower velocities. And the other thing that you also see is that actually the shape is changing in such a way that you see that it becomes actually less flattened in some ways. And again, when starting to think about, say that this is a pressure overload together with a volume overload, we know this is a volume overload, but it seems to be also that there's some evidence of pressure overload. So if there would be pressure overload, then this makes sense in the sense that, of course, if you kind of make it a little bit more spherical locally, so if you increase the radius of curvature, what you actually do, sorry, decrease in this case, so you really make it more spherical compared to there. If you decrease the radius of curvature in the Laplace way, you would kind of decrease your wall stresses also. So in the end, this makes a lot of sense. And you see that this seems to be, or intuitively, this seems to be like a good adaptation, because it might help in order to get the volume out by being bigger and especially wider there locally, because that would be optimal. And it might additionally enable a decrease of local wall stresses if there would be a pressure load. Now, interestingly also, what you see is that this change, so the more you have this athletic change, the more you see that indeed your maximum oxygen consumption increases. So from the intuitive thing that we said, so this looks indeed that this might be a better way. Now, interestingly also, is like this is not related to the heart rate. So because this means that it's not because of the heart rate that they can increase their cardiac output and then potentially also their oxygen consumption. So it's really just related to the shape. And that means that that makes it a bit more optimal. So again, this shows that there's a lot of differences in individuals. Here you see, so you go from very much athletic remodeling to a lot which have more kind of almost no remodeling, and other ones which are more towards the super controls in some ways. So there is a huge of inter-individual variability, and there's also some optimal changes that seems to be optimized for a combination of pressure and volume mode. And then together with the fact, of course, that it's the right ventricle. So we start to get a lot more information in some ways from this in order to try to understand what's the mechanism behind this, and also then how are individuals adapting to this. One of the things that you see here also is that even if you would do a control and an athlete study, there's so much overlap and there's such a wide variability that this is not an easy way to do it. So in the sense that when you have this individual changes, mostly classical statistics don't work. And so you really have to start to look at interactions, at confounding factors. I mean, what's the influence of sex in here? Are there other influences that keep a role? At some point, you have to try to see, is this related to genetics or not? This might be even related to some intrauterine conditions, as we are showing in some other studies and so on. So there's a lot of things going on and a lot of things that we don't know yet. So that's the other thing. Now, and another question is like, does it make a difference depending on the amount of exercise you do? So is there like a dose effect? Because in general, and that's what I said last time also, it's like, in general, it's good to do exercise, but potentially it's not good to do a huge amount of exercise. So when you look at things like arrhythmias and so on, and then even like life expectancy and so on, it might change or it might be related to the dose. And so here's a study that they did at Hospital Clinic here in Barcelona, where they looked at 3 groups of runners. So this is like distance runners, where they either did short, medium, or long distance. And especially the medium and long, they didn't have huge training differences. So they were kind of similar athletes in some ways. And what you saw there is when we look at the size of the right ventricle, you see that there's clearly a dose effect, which you might imagine. So in some ways, because what we said before, in order to keep on generating your cardiac output, one of the ways to do is dilate your right ventricle. So a bigger right ventricle is good in order to increase the stroke volume. And so it seems that that is indeed the case, that especially between the short and the long, that there is a difference. Now, if we're going to look at the other parameters, so this is looking at the volume, the strain, and the ratio between the ejection time and the peak time of the pulmonary artery. So this is a kind of surrogate, in brackets, of right ventricular pressures. And so what you see is that if you have increased right ventricular pressures, what happens is that actually your peak of your Doppler comes earlier, which is related to wave reflections and so on. We'll talk about that when we talk about pulmonary hypertension in a bit more detail. So this is like a very rough estimate for pressures. Now, what you see there is when you look at the different groups, first of all, when you look at the left ventricle, you see that there's no change. So there's no difference in left ventricle between the different groups after this race. Now, when you look at the right ventricle, you see, as was shown here also, so they become bigger if you do more exercise. And one of the things that you also see is that the deformation goes down, so they have less deformation in the right ventricle, especially since, I mean, you would hope that deformation goes up with exercise, because that would increase the stroke volume. But what you see is that it goes down, and you see in the short ones it does go up a little bit, but in the long and the medium group it really goes down. And similarly, you see that this ratio of the peak comes earlier and earlier, and you really see that that has a dose effect. So there seems to be also something that the pressures in the right ventricle increase with more exercise. So there clearly seems to be a dose effect. Yes.
This is addressed after exercise?
This is just after exercise. So you hope that this would be on peak exercise. Of course, this is just after the race, but they do it as fast as possible after the race. So it's like a surrogate for the exercise, the long exercise. So this is after the exercise.
That means, well, the thing is that if they are addressed and they have that dilated ventricles due to the race, and then suddenly they stop, so their cardiac output needs to go down. So it's kind of expected that the strain goes down, because if they don't.
Yeah, but this is not, yes, partially yes, but it's still the assumption that you do it quickly enough that there are changes. And the thing is, you still see different changes here, because what you would think is that if indeed the cardiac output would really drop dramatically, then you wouldn't expect these changes in the pressure. So then you would, because this is the difference between before and after the race, then you wouldn't see that. So the strain could theoretically be related to the size, but then this doesn't fit anymore. So
the heart rate, what happens?
I don't know anymore. I don't have this data here, but the heart rate will be still relatively high at that moment. So because it takes, I mean, the idea is that these athletes, or the way they did the study is these athletes come and then immediately go on the table in order to do an echo. So it is not ideal, but it's the closest that you can get. So I think this is still the exercise effect, let's say it that way, and they're not returned to baseline at this moment.
Thanks.
Now, the other thing is, of course, when you look at the ventricles, and especially when pressures go up, and especially when you need more volume, then you would think that also potentially your filling pressures would go up. So looking at the atrium is also something which is quite interesting in order to look at it. And so there's another study that they did, and they looked at left and right atria of athletes, in this case at rest. So this is a rest study. And then also in order to see whether there's differences, first of all, between left and right, and then secondly, between controls and athletes. And so as I said before, there is a fixed relationship between the size of the heart, the deformation, and the generated stroke volume. So you can put them in context. And so you can put these atria at these diagrams where you look at strain versus volume, with then, of course, constant stroke volumes in some ways, or strain versus stroke volume, or stroke volume versus size. And one of the things that you see is that in the athletes, of course, you have these very large ones. So you see that there's a shift, but again, you see that there's a lot of overlap, but there's a subgroup of athletes which have very high volumes. And what you also see is that they actually have relatively low stroke volumes, especially these ones, which is a bit weird, because you would hope that they have normal stroke volumes, but of course they have very light, small strains also. So you see here, you have athletes with large ventricles, low strains, but also relatively low stroke volumes. And this is kind of fishy. You wouldn't expect that in some ways. And you see it here also. So you see that there's a subgroup that has low stroke volumes, and then that is not necessarily kind of going together all. And here is just some kind of an extrapolation in some ways. So this is like looking at the potential to increase your stroke volume given your volume and the strain. So that means that some with these very large hearts, or very large atria in this case, but the rest of the heart will also be large. And we know that they have relatively low strain, so they could go to normal strains and then could potentially generate enormous stroke volumes. Now, the problem is, of course, if you would do that with these large hearts, you're going to get also very, very high stresses. So if you would measure the wall stress that is related to that, then you would potentially get into trouble. And so the question is a little bit these extreme ones that have a high potential, but can only do that potential at very, very high stresses in some ways. and are still kind of generating relatively low stroke volumes also, then these ones are, you can ask yourself, are these already damaged, yes or no? And this is one of the problems that we need to address at some point, is have to say like, okay, at which point is a certain amount of stress generating potential problems, and what is the best working point in some ways of these ventricles or atria in order to be fully optimized, or to be as optimal as possible.
Bart, one question. This is the stroke volume from the atria?
Atria. This is atrial contraction stroke volume.
So how is it computed then?
You can just measure it, and you can
the flow coming in as well, so no? So.
Yeah, but during contraction, virtually not. On the contrary, what actually happens is that during atrial contraction, what you have is you might have reversal flow towards in this case, towards the vena cava. So since there's no, but there's definitely no inflow in any atrium during contraction. That's definitely not the case.
But this is only like active contraction, or it's also
yes, active contraction. No, active contraction.
So
that's where it's called pre-A. So that's the volume of the atrium just before the active contraction. No, the problem is indeed when you want to look at the other parts. So the conduit function, for example, of the atrium, or the reservoir function of the atrium, then of course, I mean, it's much more difficult to look at these things, because what is deformation then? Because deformation is totally passive. Deformation is done by a combination of either pressure differences that drive the flow, or very often the ring motion. So it's the ventricle which would actually drag the ring, the mitral or the tricuspid ring, towards the apex, and thus changing the volume. So this type of analysis you can only do if you have active contraction. But again, the main message from this is that there is a lot of overlap. So there's an enormous inter-individual difference in adaptation, and there is a subgroup that has very, very large atria with things that don't fit fully with being totally optimal. And so likely they're damaged, but that's another thing to do. Now, to look a little bit further in detail on whether they are damaged or not, one of the things that you can do is, of course, to look at their change with exercise. So as we said before, when we look at, in this case, ventricles, but the ID would be the same, because myocardium is myocardium in some ways. What you see is that normally with exercise, what you hope is that your strain rate, your rate of deformation linearly increases, while the deformation itself would initially increase and then would decrease if you have a very high heart rate because of problems with filling. Now, if we look at the atria, what you now start to see, and here is the change with exercise. So you see the dot is the measurement before, and the cross is the measurement after exercise. And what you see there is that most of these atria, you can increase the strain and you can increase the strain rate. You see that for, in this case, the controls are red and the athletes in blue. So you see that especially with the smaller volumes, you see that there's a big change in both strain and strain rate. This is what you expect. There's a little bit less in the right atrium, but still the majority of the individuals have the same behavior. But if we now look at these very large ones, what you start to see is that actually these large ones are not able to change neither their rate of deformation much, nor the amount of deformation. And so here, based on this, together with the previous, what you likely can expect here, or what you likely can conclude, is that indeed there is a problem with the contractile function of these atria, and they're not able to deform neither at baseline, nor is there any change in exercise. So that means likely that there is some damage in these atria. And one of the things that's also interesting, you see some in the left atrium, but you see much, much, much more in the right atrium of these cases. And so again, this points to the fact that there's a differential adaptation in right and left atrium. Now, here's, again, this being put in a little bit of perspective, and now actually also looking at the segmental response. And now you're going to see that, so we have the two parameters that can change. So you can change your strain, you can change your area. So the ideal would be probably to dilate a little bit and to increase the strain. That would be the kind of most logical or the best way to increase your stroke volume without the need to increase the heart rate very much. And you see that in the left, in the right side. So it's all right side. What we see in the basal part. So you see here, this quadrant is an increase in strain and an increase in volume, and that seems to be quite okay. And actually here is again looking at the difference between these shorter and longer distance running. So it's medium and long, I think, in this case. And then what you see is that there are quite some which are in the area where they can increase the size of the RV, but at the cost in some ways of the decrease in the strain. Now, this can be also because of the high heart rate at some point that you cannot fill anymore. But of course, if you have a larger size, then you might be able to fill better. So it will be a combination of things. And then you see that there's few individuals that in the basal part of the ventricle that they decrease the area actually and decrease the strain. Of course, this is really deleterious for increasing the stroke volume, and they have to go to the very high heart rate. Now, if we look at the apical version, what you see now is that there's actually very, very few individuals that can actually increase their strain. And why would the apex be so much different than the base? This would not be very logical when you look at stress related, because as we said before, the apex is normally much, much more rounded. So intrinsically, an apex has much lower wall stresses. So it's unlikely that this is something which is pressure related, because the base would be much more influenced by the pressure. But what this is likely the case is what I've been saying before, is that many of these athletes, especially the ones that do quite a lot of exercise, their apical area is trabeculated. And what you see is that they just don't have the capacity to increase their deformation anymore because of the fact that there is no volume to eject. So they cannot do that. And so you see that what you see is that the apical part is actually much worse kind of reacting to exercise in some ways, or at least is clearly not contributing as much as the basal part in order to increase the cardiac output. And when you then start to look, for example, at strain curves, what you see is in general, some of these things are happening. This is actually at baseline. What you also see is that there are actually differences when you start to see in some individuals. In most individuals is what you expect is that the deformation of base and apex, especially the longitudinal deformation, is at rest more or less the same everywhere. So you see that these curves overlap. But here you see, for example, one where you now see that this one is predominantly apical, although, but you can't see it too much. I think the trabeculation in this one is kind of reasonable, but what you clearly see is that there's a decrease in the base, but also at the same time, just look at when we compare to the onset of the QRS complex, so that's in principle when the contraction should be starting, you see that these here immediately start to deform at the onset of the QRS complex here also. But what you see here is that there's a long time where there's actually no shortening of the ventricle, which means that you have a very long isovolumic contraction time, which mostly relates to some problems with contractility. And what you then see is you see that this basal part is kind of really reacting very abnormally, and there's almost no deformation. So you see that there's a lot of things which are interacting. So we have regional differences which are related to the apical hypertrophy, for example, and the trabeculation, which means that your exercise response might be hampered in the apex. But on the other hand, what you see is that there's also individuals where you see that already in baseline, there seems to be something going on with the base. And that makes a lot more sense in some ways. It's like if there is kind of long-standing pressure loading, of course, we know that the base is mostly flatter in some ways. So in the Laplace way, it's always the base which would be kind of stressed much more. So here again, what you see is this might suggest that there's something wrong with this base already of this ventricle. And then you start to see, when you look at some of these studies that kind of look at this together, so then you see that indeed in athletes which have most of the right ventricular dilatation, what you see is that they actually have the worst kind of deformation. And then you see that in principle, overall, the apex contributes more, but what you also see is that the apical standard deviation is much, much, much more than the rest. So what you have here is you have two effects going on at the same time. One is the effect that the apex has, in principle, the lowest wall stress, so should be able to cope much better with increases in pressure if your exercise is related to pressure increase. But on the other hand, you have the morphological remodeling, which can get worse, and that makes then that you cannot get the deformation. So here again, when you do these
measurement error, sometimes the apex is not fully in the image.
It could be in principle, but what you see is in these studies, they mostly try to really focus on this. And also, it's like, if it really would be measurement errors, I mean, I don't think you would have these large things there. So I don't think it would be, measurement errors can contribute. That's definitely the case. But it's also clearly the case that there's these two kind of contradictory types of remodeling in some ways, or two different effects which are going on at the same time. So you actually don't have enough information. You really should combine this then with information on, for example, what would be the volume without the trabeculations, for example, or what would be somehow the hypertrophy of the trabeculation, which it's very difficult to measure. That's the problem. Like, not even in MRI you can easily measure this, maybe with CT, but even then you're not going to do a CT, of course, in these athletes. So, but it also shows, in some ways, partially, as you say, it's like when you do this type of statistics and to be able to interpret it. So people have interpreted this as like, okay, the base is worse than the apex and the apex contributes a lot, which is partially true. But on the other hand, there's several confounding factors or changes that can be going on at the same time and that are individually dependent. So in some ways, doing these population statistics here, in the end, make it difficult to interpret it. So it's really, we need to go to different ways to look at these adaptations, is including all the relevant information, and then much more looking at how some individuals do these adaptations different than other individuals. So again, this is potentially where you do some kind of this kind of similarity-based machine learning or things like that. Could be quite interesting in trying to figure out all these different influencing factors at the same time. Okay, I think that's enough for today. Thanks again, and see you next time.